Good evening, ladies and gentlemen. You're welcome once again to our webinar series organized by Association for Fertility and Reproductive Health, AFRH Nigeria. We have a very highly informative and exciting topic for discussion today. Our webinar topic for today is complications and prevention in medically assisted reproduction. And it promises to be highly informative and understanding all the risk involved in this procedure and implementing prevention strategies is very crucial. So I want everyone to sit back and expect a mouth-watering presentation. The presentation will be handled today by an erudite speaker and publisher in person of Professor Alexander Owolabi. Co-moderating with me today is Dr. Michael Ogunkoya. And without wasting time, I will hand over to him to give us some essential information from the Secretariat. Dr. Ogunkoya, over to you, sir.
Thank you, Dr. Kisoya. It's been a pleasure serving on the platform on AFRH, our very, very important and loud voice in the area of reproductive medicine. Today's topic, as enumerated by Dr. Kisoya, is going to be a very exciting one. And as far as I'm concerned, it embodies what ART stands for in totality. Remember, in our medical school days, teachers used to tell us that if you know everything about diabetes mellitus, you know everything about medicine. Similarly, I make bold to say that if you are able to align with today's topic and listen attentively, you will have reached a mighty goal in the area of reproductive medicine, because hardly is there any area of it that will not be touched. Ladies and gentlemen, indeed it's a pleasure to be associated with today's topic. But let me make some key announcements, which are very important to us. You are all aware by now that we have an oncoming conference very soon. Please endeavor to register for this conference. It's going to be one like none before. And join us in all our social media platforms in this regard. Thank you very much. As far as today's talk is concerned, please drop your questions in the Q&A section of this platform. And then at the end of the day, when our professor has finished his talk, you'll be able to ask relevant questions. And of course, you're going to get very rewarding answers to these questions. At this juncture, I'm going to hand over back to Dr. Kisoya.
Thank you very much, sir, Dr. Ogunkoya. That was just very much on point. Before our speaker comes up, I will be reading his profile. And I'm sure by the time I'm done, everyone will agree with me that he's not just erudite, he's the man that is qualified to discuss today's topic. Professor Alexander Owolabi is a seasoned obstetrician and gynecologist, as well as a fertility specialist of over 30 years experience in reproductive health and community service. He's a very passionate IVF expert and practitioner who enjoys making everything about IVF very simple, demystifying every stigma attached to infertility and IVF with every available academic and clinical platform. He currently serves as head of the Department of Obstetrics and Gynecology and Perinatology at Obafemi Awolowo University, and also a honorary consultant obstetrician and gynecologist and fertility specialist to Obafemi Awolowo University Teaching Hospital Complex, Ile-Ife. He is a fellow of the West African College of Surgeons, and he holds a master level postgraduate award in assisted reproductive technology at the prestigious Warwick University in Coventry NHS Trust in the United Kingdom. He obtained a Master's of Community Health degree at Obafemi Awolowo University 2003 with bias in health education and community service. He shares his time with teaching, leadership, and clinical practice. Professor Alexander Owolabi founded the Balm of Gilead Specialist Hospital, now Balm Agek Fertility Hospital Limited, Ile-Ife, Osun State, Nigeria. He led groundbreaking effort in fertility technology, including Nigeria's first IVF baby in Osun State. He gave the 306th inaugural lecture of the Obafemi Awolowo University titled "None Shall Be Barren: Reproduction Against All Odds, the Role of Assisted Reproduction Technology," on the 22nd of August, 2017. He is a member of many professional bodies, including AFRH, SOGON, FIGO ASRM, ESHRE, International Society of Ultrasound in Obstetrics and Gynecology. Professor Owolabi is widely traveled and has made many scientific presentations, both in local and international conferences. He has several scientific publications in peer-reviewed journals, in local and international high-impact journals, cutting across fertility, pregnancy, maternal-fetal medicine, and he pioneered and popularized the use of cesarean mammectomy. So join me in welcoming Professor Alexander T. Owolabi as he makes his presentation now.
Thank you very much, Dr. Akinsoya, for the introduction. I want to appreciate AFRH for asking me to take this topic, and I believe that God will help me to do justice to it, because as Dr. Ogunkoya said, this topic is very important and is very useful for practitioners in the in vitro fertilization and ARUT setup, because you need to know what are the complications and preventive measures in medically assisted reproduction, which involve ovulation induction, intrauterine insemination, in vitro fertilization, ICSI. The teaching will go through these topics. Introduction, we look at ovarian hyperstimulation syndrome. We also look at the problems that are associated with multifetal gestation. We also look at ectopic pregnancy, heterotrophic pregnancies, which are very common with medically assisted conception. And miscarriages is also common. Birth defects, these are things that are associated with reproduction and with medically assisted reproduction. Then the medical complications and complex cases of oocyte pickup. We also look at maternal morbidity and in medically assisted reproduction treatment types. Again, there's a question of the fact that is cancer incidence increased in medically assisted reproduction? These are things that we need to look at. Medically assisted reproduction has revolutionized the treatment of infertility, offering hope to millions of women worldwide. However, medically assisted procedures like IVF and ovulation induction can be associated with complications. Two significant concerns are ovarian hyperstimulation syndrome and multifetal gestation. Understanding these risks and implementing prevention strategies is crucial to ensure safe and successful outcomes. Effective management and patient education can minimize complications, optimizing the chances of healthy pregnancies and live births. The new report published by WHO in 2023 showed that 17.5% of adult population, roughly 1 in 6 globally, experiences infertility, showing the urgent need to increase access to affordable, high-quality care for those in need. It is very important that even WHO has declared infertility as an epidemic disease. They have labeled it as a disease because now the incidence of the lifetime prevalence of infertility is 17.8% in high-income countries and 16.5% in low and middle-income countries, further buttressing the fact that infertility does not discriminate where the rich and the poor are affected, almost in equal proportion. Infertility can cause significant distress to couples and their loved ones, ranging from stigma, financial hardship, affecting people's mental and psychological health. Infertility has led to divorce, ostracization, and a lot of marriages have been scattered. And it also affects infection rates, especially HIV and other sexually transmitted infection, when people are now going out to find out, to try and fulfill their reproductive capacity, even outside the family, trying other partners. So anything that can be done to ensure that reproductive treatment is safe and bring good results is worth it. So that is why these medically assisted reproduction complications need to be mitigated and to also help to increase the success rate. According to the ICMAT and WHO Reproductive Dictionary, IVF is a sequence of procedures involving the extracorporeal fertilization of gametes. It includes traditional in vitro insemination and ICSI, according to Grocery 2017. In the IVF cycle, we have the various stages. The stage of stimulating the ovaries carried out to create oocytes, oocyte pickup, which is performed for their subsequent fertilization in vitro. Extracorporeal, that is in vitro fertilization, is carried out by oocyte insemination or intracytoplasmic injection. Cultivating the embryos in a laboratory for a maximum of 7 days, most of the time 5 days, the blastocyst, with subsequent embryo transfer into the uterus, we complete the cycle of the medically assisted reproduction. Now, complications of medically assisted reproduction ranges from mild to life-threatening conditions. Some of the complications can either be due to the procedures such as bleeding and pain at egg retrieval or superimposed infections. The incidence of ectopic pregnancy and heterotrophic pregnancies are increased compared to natural conception. The same thing with preterm birth and low birth weight. All this has consequences both on the babies that is delivered and the mother involved. The ovarian hyperstimulation syndrome and multifetal pregnancies are the most feared complications, which will be discussed in more details. Now, ovarian hyperstimulation syndrome remains one of the most dangerous and unfortunately frequent complications in IVF cycle because it is one complication that can lead to death easily. And as such, one need to do everything possible to try and prevent it. OHSS is easily preventable if one is always vigilant and adhere to the basic principles of thorough analysis of anamnesis and clinical laboratory data to timely identify factors predisposing to OHSS and choose the most optimal ovarian stimulation protocol to prevent it. Despite this, OCSH can still happen during ongoing ovulation stimulation, during egg retrieval, embryo transfer, or even after the completion of the IVF cycle. OHSS can still surface. Therefore, detailed methods of diagnosis, treatment, and prevention of these formidable complications will be covered in this presentation. According to the Grocery 2017, ovarian hyperstimulation syndrome is defined as an excessive systemic response to ovarian stimulation, characterized by a wide range of clinical and laboratory manifestations. Thus, OHSS is a complication of infertility treatment characterized by several specific symptoms. The main ones include abdominal bloating, ovarian enlargement, hemoconcentration, and the development of respiratory and hemodynamic and metabolic complications. These are life-threatening situations. OHSS has varied degree of manifestation from very mild with little or no intervention to the critical level requiring multidisciplinary team care. And in fact, one need to be aware of this, that if OHSS is getting out of hand, you need to refer to a center that has a multidisciplinary approach. If you cannot handle it as a, a standalone practitioner. In its mild form, it has been estimated to have a prevalence of about 20 to 33% and about 3 to 8% in the more desperate, severe form. You have the enlarged ovary with multiple follicles, classically seen on ultrasound scan. This picture also, we have a natural cycle on the left. In the middle side, we have the control ovarian stimulation. And of course, on the right side, we have the ovarian hyperstimulation in pictorial form in this slide. Now, I'm going to discuss ovarian hyperstimulation syndrome through these topics: risk factors of OHSS, etiopathogenesis, the classification, how to diagnose it, and the treatment modalities, and more importantly, the preventive aspect. The risk factors to OHSS is, we need to know that there are two groups of risk factors. In the latest review of the literature that I went through to the development of OHSS, now, predisposing factors are the start of stimulation, not related to the IVF procedure. That means that these predisposing factors can be detected before you start your stimulation, and that means that we will look at those factors. Then the predisposing factors related to IVF procedure itself. That is, after starting stimulation, there are factors that can be seen, detected, that you know that there's OHSS is going to form, and that you need to take some step to curb it. Different guidelines have been reviewed: the S3 guideline, the RCOG, the SRM, the Canadian Society for Reproductive Medicine, the Australian Prenatal Practice Guidelines provide varying criteria for risk assessment. The next table provides a conservative version of the various guidelines, which have been amalgamated together. We have the predisposing factors before the start of stimulating, not related to IVF practice. All these predisposing factors, we have the PCS and AMH that is greater than 3.4 nanogram per mil, not milligram per mil. This has been synthesized from the various guidelines. And we have the low BMI, AFC count, ultra follicle count of 18 to 20 per ovary. Again, let me look at it here. Let's look at it here. Predisposing factors before the start of the stimulation, not related to PCOS, high baseline AMH. When we have anything like 3.4 nanogram per mil, and then we have high antral follicle count, greater than 18 to 20 follicles, and then we have the follicle number per ovary count, FNPO, that is 18 to 20. These are average from the, from all the guidelines. Then we have the low body mass index of less than between 18 to 20. Young age group, a patient that is less than 35 years old, and the history of OHSS in previous cycles, or the history of costing, which is one of the interventions that we use to prevent OHSS from forming, or if it's developing, how to mitigate it. The number of oocytes retrieved during previous in vitro fertilization is also significant when they are up to or greater than 18 to 20 in such cycle before. We know that this woman is predisposed to OHSS in the next cycle. Now, there are predisposing factors related to the IVF procedure itself, which is, when you OHSS development with ACG, ovum pickup, and embryo transfer. These are the factors that we can identify during the procedure itself when you have started stimulating. When you are stimulating a woman and you have more than 18 to 20 follicles, larger than 10 or 11 millimeter on the ovary, on the day of ovulation trigger, you know that this particular cycle is going to be fraught with danger of ovarian hyperstimulation syndrome. Now, when you have a high estradiol concentration in the blood of more than 3,500 picogram per ml. A high dose of gonadotrophin, if you're already using high dose gonadotrophin, because IVF, the aim of stimulation is to produce multiple follicles, so that you can harvest number of eggs. But at the same time, it's also dangerous. And the gonadotrophin, especially when you have a patient that has a high risk factor, can lead to this multiple follicular development. Large number of oocytes retrieved, 18 to 20, and ACG used as an ovulation trigger. One of the major factors of development of OHSS is the use of human chorionic gonadotrophin, which has over 6 to 7 times the strength of luteinizing hormone. It's very powerful and it stays on the receptors for a longer time. And that is the major cause of ovarian hyperstimulation syndrome. A high amount of fluid in the patch of Douglas. When you are monitoring, you are doing follicular tracking, and you are seeing increased fluid in the patch of Douglas, and you should be suspecting that this particular cycle will be fraught with ovarian hyperstimulation syndrome. And you'll already be planning what to do as to mitigate it. Either you are going to freeze all the eggs, or you are going to freeze the embryos, or you are going to use other treatment which we are going to mention as the presentation goes on. Addition of ACG for lutein phase support after embryo transfer, in old practice used to use ACG to improve the lutein phase support. In fact, it should not be done again because of the risk of ovarian hyperstimulation syndrome. The consensus of opinion from literature review shows that since gonadotrophin doses correlate with the severity of OHSS, it is recommended to reduce the initial dose of the gonadotrophin to 100 to 150. I'll just quickly go back to the table I was looking at before to make sure that everything there has been looked at. Factors related to the IVF procedure is what we have checked. High doses of gonadotrophin, large number of oocytes being recruited and being tracked along the line. Okay, high amount of fluid in that patch of Douglas. Then if there's pregnancy can lead to secondary OHSS. Very important. If you're already suspecting OHSS in a particular cycle and you are going to transfer the embryo, you need to be wary, because if that embryo is transferred, that will kickstart another set of OHSS from the pregnancy itself, because the pregnancy will be producing human chorionic gonadotrophin in a large amount, and the ovary that's already enlarged will continue to get enlarged, and that can lead to very serious complication. I have experienced one before, and I don't want to experience another one again. We didn't have freezing facilities that time, and we counseled the patient, but he insisted that we should transfer the embryo. Transfer the embryo, started having ovulation. I had to refer this patient out to a center with multiple, multidisciplinary approach of management, and she was taken for that management. Eventually, she lost that pregnancy because OHSS you may need to terminate the pregnancy that is ongoing, because to save the life of the mother, when the thing is uncontrollable, we are still going to get to all those. Administration of ACG during lutein phase support should not be done again. And so so the risk factors, as I said, in the research has shown that in women in the very high risk group, very high risk group with a combination of several risk factors, something like PCOS combined with AMH greater than 6 nanogram per ml, arterial follicle count of greater than 18, young age, low body mass index, the use of low doses of gonadotrophins combined with letrozone has significantly reduces the risk of OHSS without reducing the rate of pregnancy and live birth. Letrozone present in the ovarian stimulation protocol. I mean, when it's introduced to the ovarian stimulation protocol, especially when you have a patient at risk of OHSS, lowers estradiol levels in the serum, thus influencing the pathogenesis of OHSS and reducing its incidence. So major factor, reducing the gonadotrophin stimulation to between 100 and 150 international units when you have a high-risk patient. And when you have an extra high-risk patient, when you introduce low-dose gonadotrophin, as I mentioned, and the use of letrozone, All these two combination factors will help to mitigate the OHSS syndrome situation. This is one of the most feared complications I've mentioned earlier. I'm going to go further to where the next area of discussion. The major area now that we have is in the area of etiopathogenesis, which I said does not occur unless an ovulatory dose of ACG is administered. It's well established. It is ACG that causes OHSS to happen. And that is why when you use the antagonist protocol, you are going to prevent the use of ACG in the trigger, and that will help to mitigate it. So it is very important that we understand that it is ACG that is the major culprit. Exogenous ACG induces massive luteinization of granulocyte cells, which leads to the production of vasoactive substances such as vascular endothelial factors, VEGF, IL-8, IL-6, TNF, and angiotensin B, etc., that increase the vascular permeability. That is the pathogenesis. General vascular permeability is increased. There's shift from a fluid from the intravascular system to the third space. And this mainly manifests as ascites. When ascites is developing, there's discomfort. And of course, the ovarian enlargement also causes displacement. There's bloating, there's nausea, there's vomiting. And if the ascites is not aborted or reduced or relieved, then you can lead to pleural effusion. Pleural effusion, it can even lead to pericardial effusion. When a woman is having pleural effusion, that woman is at danger of death and need a high-level approach to its management. Such massive luteinization is not observed when the final steps of oocyte maturation are achieved with drugs other than ACG. The effect of ACG is related to its high biological activity, which is 6 to 7 times that of endogenous LH because of the longer half-life. So pathogenesis in the simultaneous ovarian cycles, hypothalamic pituitary feedback mechanism limit follicular recruitment, and only one follicle becomes dominant and eventually ovulate with mid-cycle LH such. That's the natural cycle. This feedback mechanism is blocked as a result of pituitary downregulation in control ovarian hyperstimulation, which is seen in IVF. This results in numerous follicular development. The sustained development of numerous large antral follicles and administration of exogenous ACG leads to excessive production of vascular endothelial growth factors. Now, with every ovary stimulation comes the risk of OHSS depending on the what you use. And then the classification of OHSS is based on the time of onset. Early OHSS occurs within 9 days of oocyte retrieval and is related to the ovarian response to stimulation and exogenously administered ACG trigger. Late OHSS from 10 days. This is related to endogenous ACG from ongoing pregnancy or when exogenous ACG is administered for luteal phase support. And so that is it. Now, another way of classifying OHSS is whether it is mild, moderate, severe, or critical. We are going to look at this classification and the strategies to look at them. This slide is cloudy, but when you look at it, it is very useful in trying to summarize the activity of OHSS in terms of classification. When we have the mild cases, we have abdominal discomfort, pulling pains in the lower abdomen, sometimes abdominal bloating. And the ovarian size is between 5 to 10 centimeters, and fluid in the cavity is less than 300 mils. Biochemical state is stable, no changes. Treatment is an outpatient basis. Patient is weighed daily, and then is seen to observe, follow up on outpatient. The moderate severity cases, we have the overall conditions is slightly disturbing. Discomfort is there, and abdominal bloating is increased. There's nausea, there may be vomiting and diarrhea may occur. And then this increased body weight. The ovarian enlargement is about 8 to 12 centimeters. And we have in the abdominal cavity up to 1,000 to 300 ml of fluid, ascitic fluid. Then the hematocrit is increased. There's already hemoconcentration because of intravascular dehydration. Leukocyte is also increased to 15,000 millimeter, and then we have estradiol level up to 4,000 picogram per mil. And we have a hypoproteinuria, hypoproteinemia, So this outpatient or admission case, and this case need to be explored. The obstetrician and gynecologist need to look at it, and it's a teamwork. Then we have the high severity case where there's dyspnea and tachypnea and intractable vomiting, the extension in the abdomen, and increase due to ascites, and weight gain of up to 1 kilogram per day. And then there's hypotension, and this may lead to poor development of the organs, organ perfusion. And there's also hydrothorax, and there may be pericardial fluid increase. In this case, hematocrit may be rising up to 55%, glucose up to 25,000 millimeter cube, and creatinine is increased, and sodium is reduced, potassium is increased. There's biochemical derangement, and when we look at the liver factors, all the liver enzymes are increased, and then there's hypoalbuminemia. Then in the critically severe case, we have additional symptoms of moderate to severe anuria. There may be anuria, arrhythmia, massive pulmonary edema, and Asaka may step in, and we have, atrial thrombosis and respiratory multi-organ failure. This is very dangerous case. Your ovarian enlargement may be up to more than 12 centimeters, and we have ascites fluid up to 4,000 mils. And then the deterioration of the biochemical parameters. This patient needs hospitalization and intensive care approach to his management. This is also, this table also shows the various categories. And we have the ascites, class 1, class 2, and class 3. We have the class 1 is visible only on ultrasound. Then class 2, there's already enlarged abdomen, bulging, and that abdomen can be monitored by using abdominal guard measurement at the level of umbilicus, on a daily basis. And class 3, so pronounced bloating. So this is, and then of course we have the liver enzyme, the aspartate aminotransferase is increased more than normal. Alanine aminotransferase also increased, total bilirubin is increased, and the gamma transferase is also increased. Electrolyte derangements I've mentioned, low sodium, then increased potassium, and of course potassium is very dangerous when it's increasing. Hematocrit is also increased, and the kidney function will be less than, critically less than optimal, anuria may set in. How do you diagnose ovarian hyperstimulation syndrome? This diagnosis is made by clinical history and transvaginal ultrasound. There should be history of ovarian stimulation followed by admission of human chorionic gonadotropin. We need to find out. The number of collected oocytes during that period is also noted, and this will also help us to classify the disease. There must be regulation of embryo transfer as part of the way to mitigate against OHSS formation and multifetal gestation cases, and it's very important. Now, another major area of problem that we have is multifetal gestation and the attendant adverse outcomes. In some cases, there may be need of selective fetal reduction, which may limit the complications. Again, this also affects OHSS. That's why I'm mentioning it here. Recognition of a high-risk patient, such as those with previous history of OHSS, PCOS, and low body mass index, and then use a best protocol approach to it is very important, so that we can mitigate the effect of OHSS. It is important to highlight some of the preventive measures, especially for common complications and medically assisted reproduction, to avert the danger associated with them. Now, how do we prevent OHSS? The keys to prevent OHSS are to identify the potential risk factors for the individual patient and modify treatment to avoid this occurrence. This includes individualized ovarian stimulation, I've mentioned that before, avoidance of HCG, and also selecting the particular case before the onset of the program, and during the stimulation, you're already noting that this may increase. The use of dopamine agonists, carbagolin, cholinogolin, and dopamine also help to mitigate the vascular endothelial growth factor production, which will help to reduce the vascular permeability to the fluid overload that cause the major symptoms of OHSS. It's very important. Now, this table give a summary of prevention and treatment of OHSS in a flow chart. Prevention before IVF, the use of aspirin is also noted, and the use of metformin, 1,000 to 1,500 milligram, 3 months before the onset, because we already identified that patient with PCOS is, at high risk factor for OHSS. So metformin will be useful to lower it. Then prevention during IVF itself, the protocol to be used, antagonist protocol, very useful to help to prevent OHSS. Now, the stimulation level, we have mentioned that 100 to 150 milligram. Then the use of carbagolin, we have the Dostinet case, 0.5 milligram, 5 to 8 days from the trigger date. Add carbagolin to the treatment, 0.5 milligram, for 5 to 8 days. Then, of course, you still continue about carbagolin. This time around, the dose is about 1 milligram 1 milligram per day for another 5 to 6 days from the puncture date. And then antagonist protocol can be added to help subcutaneously 3 to 7 days from the time of puncture. Use the pattern programs using the Centrelli, for instance, 0.25 milligram. Then you can freeze all the embryo. Then you can also transfer to another cycle. That is one of cycle cancellation. If you don't have capacity to freeze, then you can cancel the cycle and then replan the program again. It is better, because to get into the problem of OHSS in a massive way is very dangerous. The use of albumin has been noted, especially infusion of albumin at the time of grand puncture. Then paracentesis for acidic class 2 and 3 is very important. Hospitalization is there. Paracentesis is to reduce the acidic flow, and that is a major area of treatment for OHSS. This is through the transvaginal scan, guided ultrasound guided transvaginal scan. You aspirate the fluid into a container, and we have seen that we have aspirated up to 5 liters, and that will bring quick relief to the patient. And of course, we continue to monitor, because we may need to do 2 or 3 sessions of aspiration before a patient get relief completely. So aspiration is very important and is advocated. Transvaginal is the method of importance now. In those days, we used to do transabdominal aspiration, but transvaginal is better, and that also helps. Now, the summary of the preventive strategies also include pre-treatment before stimulation, assessment, thorough assessment, changing the trigger method, oocyte retrieval, looking at use of albumin, and elective cryopreservation of embryos, and transferring at another time, and also the introduction of carbagolin. It's also helpful. This is a flow chart also that helps to look at you to help monitor whatever we are doing in terms of the treatment. Are we really doing the correct thing? Looking at the flow chart, looking at the urine control, the osmolality of the urine and electoral cycle, clotting parameters need to be checked, and you may need to use anti-clotting factors, low molecular weight heparin also help. Liver function tests and pregnancy tests, pelvic ultrasonography, the use of invasive hemodynamic monitoring also be used. Medical treatment, I mentioned that correcting the circulatory and electrolyte imbalance, correction of electrolyte imbalance, plasma expanders, very important, anticoagulant, clinical and laboratory evidence of thromboembolism must be looked at. Prostaglandin synthesis inhibitors could be hazardous and should not be used. Antihistamines are not effective. Danazol is not effective. Diuretics can deplete the intravascular system further. But dopamine can be used in oliguria patients. Laparotomy also may have to come in. Experienced surgeons we need to operate, because there may be rupture, there may be torsion, there may be ectopic in terms of, associated with ovarian hypertrophy syndrome. Then hemostasis must be achieved. Again, laparotomy may be done for hemostasis to be achieved. Again, if there's unwinding of or twisted ovarian cyst, then laparoscopy can be useful. Aspiration of acidic fluid, also transabdominal paracentesis and transvaginal aspiration. Advantages: it improves the symptoms, improves renal function and urine output, and shortens venous return and cardiac output. It improves venous return and cardiac output. Then precautions to be taken. You need to sonography guidance, replacement of plasma protein, and repeat aspiration as required. Very important. And so, OHSA prevention, as we have said, this is a summary. Now, multifetal pregnancy, twin gestation is the commonest, 5 to 10%, with the use of clomiphene citrate for ovulation induction, and as high as 20 to 30% in in vitro fertilization. There has been a steady rise in the incidence of multiple gestation in the last 30 years, mainly due to uptake of assisted reproduction technology and the increase in average maternal age at conception. Multifetal pregnancy is a big major problem, and the tendency to, of course, in this environment, patients love to have twin gestation, triplet, and the practitioner must be cautioned, because if you follow that, there can be serious consequences. I had a case which I transferred 4 blastocysts to this particular woman. Within 1 week or 2 weeks, she was already shivering. The father called me, "What is happening to my daughter?" We looked at it quickly, and the referring doctor did a scan. He said he saw 6 fetuses. By the time he got to us, my assistant did a scan. He saw 7. By the time I did the scan, we saw 8. And the woman was symptomatic, very sick, and needed intervention. And so we need to quickly do fetal reduction before 8 weeks. And, we reduced 4 of the fetuses, and the pregnancy continued, and baby was delivered successfully at 33 weeks, having a quadruplex. That's the first set of quadruplets. Since that time, I've been lowering my transfer to 2 to 3 embryo, and I know that nationally we should aim at not transferring more than 2 embryo. These are part of what we use to prevent a multiputal pregnancy, because multiputal pregnancy, there can be twin-to-twin transfusion, there can be anemia, it can lead to ectopic pregnancy, which can lead to rupture of the tube, because the pregnancy have been transferred and migrate into the tube, because there are many of them, and that can lead to ectopic pregnancy, which is on its own, it's another major problem. Even though a significant proportion of infertile patients consider multiple gestation to be an ideal preferred treatment outcome, especially in an African setting, where there's high premium for childbearing, it is associated with significant adverse outcome, as I mentioned, as such. Then the other complications include birth defects, associated with spinal bifida, as well as common compared to single gestation. Miscarriages is increased in circumstances of multiple gestation. Twin-to-twin transfusion occurs in about 15% of monochorial presentation. Selective fetal reduction in the event of higher order pregnancies is a recognized way of limiting the complication. I just gave my own personal experience. Now, another complication that can happen is the complication during oocyte pickup. The clinician performing OPU should be careful of performing the following to prevent the following rare complications: bleeding during OPU, injuries to during OPU to structures like bladder. You can puncture the bladder, and they may be, that's why the bladder must be empty before ovum pickup. Very important, because when you puncture the bladder, it can lead to intrabladder bleeding, and then that can cause a serious hypotension. I've experienced a case that we need to quickly discontinue the ovulation, the ovum pickup, and catheterize the woman, give a lot of fluid, and luckily, of course, there is hematuria. The bleeding mitigated, and there was no clot retention, because one of the danger is clot retention. That means that you need to go and perform laparotomy to relieve that, So, and we continued. That woman was transfused with 2 pints of blood to secure her life. And so it is very important, it's critical. And then in the case of OHSS2, there must be the need to monitor the patient, either it is a donor or an no-neck patient, because it's very important. The physician must give number that the woman can call. They must counsel them to know what to expect, the symptoms. When there are symptoms, this will refer you to the center where the patient has been treated. And wherever the patient may be, the onus is on the practitioner to fish out the woman wherever it may be. If we need to send your ambulance to go and pick such a patient wherever it may be, especially a donor. Even if a donor has been referred to you from any other place, you are the practitioner. You are the one that will oversee that and make sure that that woman is secure, her health is secure. Very important. And so there are cases where somebody who has ovarian hyperstimulation syndrome has been treated in another clinic where they don't understand what is happening. They just did a scan and saw a large ovary and took the woman to the theater, and they removed the ovary. They said, this is the thing that is wrong with you, because they saw an enlarged ovary, which is benign, but because of lack of education. And so medical practitioners that are not even into IVF need to know the complications associated with IVF operation, so that in cases of hyperstimulation syndrome, when there's large ovaries and which is detected by such a man, we know that this is the management is to have a conservative approach. It's very important. So empty follicle syndrome, in the series, injury to other structures, infection can also occur, especially in OHSS2, infection of the ovary can occur. There can be torsion of the ovary when you during ovarian pickup, or along the line there can be torsion of the ovary, and that will need to be dealt with. But you need to be aware that this thing can happen. There can be empty follicle syndrome. In the case of Mayer-Rokitansky-Kosa syndrome, there's no uterus, but the ovary is there, and you may have to do a transabdominal pickup of the follicles. Special cases also present with technical difficulties that need to be, you need to brainstorm on if there are problems. Then the vascular structure of the pelvic, you need to understand it, because when you are, want to puncture an oocyte, you are also seeing the vessel. If rotating your probe will show whether this is a vessel or not. By the time you rotate 180 degrees, if it's a vascular system, it will show. What you think is a follicle, will show that this is a blood vessel. And especially we have the internal ciliary arteries, we have the uterine artery surrounding the ovary. And so again, the challenges of trying to avoid puncturing the blood vessels is very important. We need to look at that. Then maternal morbidity and medically assisted reproduction is also common. Morbidity like blood transfusion, as I mentioned the other time, unplanned operation during the procedure itself, admission at ICU, eclampsia in cases of multifetal pregnancies, unplanned hysterectomy. We are talking about the outcome, because when a woman is bleeding, has placenta previa because of multifetal pregnancies, and they need to be operated, it may lead to hysterectomy. Ruptured uterus can occur. And so these are factors that we need to look at. More invasive medically assisted reproduction treatment like ART and IUI are associated with higher order of maternal morbidity, whereas less invasive treatment are not. This relationship is partially explained by higher prevalence of multifetal gestation and obstetric comorbidities in people undergoing more invasive treatment. But the persistent association suggests so fertility itself may contribute to maternal morbidity. Now, without is cancer incidence increase in medically assisted reproduction? Without inherent genetic certain diseases or familial cancer predisposition, IVF treatment, including the medications, are not precancerous. Fertility drugs do not cause ovarian cancer and do not predispose straight to ovarian cancer or any other cancers without certain inherent genetic familial factors or predisposing factors. They are mostly natural molecules. IVF may mimic the natural process. The IVF drugs mimic the natural process. The drugs are natural molecules or derivatives, and so are not cancerous. Since 40 years, 15 million babies have been delivered through IVF. The cancer risk to the babies and the IVF processes itself have been found to be at par and not to exceed natural or prevalent population cancer risk. IVF processes or the medications are safe. The Danish National Infertility Women Cohort 2024-2025, this large register study examined ovarian cancer after fertility treatment, explores roles of infertility factors, evidence for ovarian hyperstimulation and invasive cancer is limited. Risk may be higher in women who remain nulligravid after treatment. The evidence has shown that the infertility treatment does not cause cancer. But women who remain infertile, maybe they have undergone IVF, they have undergone many cycles of IVF, but they are not pregnant, they remain infertile. The infertility factor itself is the one that will lead to the cancer cases. And so IVF is safe. In conclusion, high premium is placed on childbearing, especially in our climate. The quest of higher educational attainment and career progression has made many women to start their families late. Hence, the need for medically assisted reproduction has been on a steady increase. In view of the increasing uptake of medically assisted reproduction in the form of ART, efforts will be made at ensuring that the potential complications are mitigated in order to have desirable outcome. The attendant complication that is associated with multiple gestation throughout the course of pregnancy, delivery, and postpartum period calls for strict guidelines that will, with regards to the number of embryo transfer during an IVF cycle, as this varies greatly with individual practices. Couples seeking IVF services should be properly counseled to guide their expectation with regards to OHSS is considered as a procedure, is considered as a failure. OHSS-free ART IVF clinics should be the norm today. These are my references. Thank you very much for your attention, and God bless you.
Wow, thank you very much, Professor Alexander Owolabi, for that very scintillating and informative presentation. Without much delay, I want to call on my co-moderator, Dr. Ogunkoya, to please take the Q&A section, and let's move on with the webinar.
Yes, thank you, thank you, thank you. That was scintillating, overwhelming, if I may say so. We need to thank our lecturer for a job well done. I've tried to peruse the Q&A area, and there doesn't seem to be one at the moment, and I think I have reasons for that. But if we can take live ones, please indicate your intention to do so. I will kick off by saying that I felt overwhelmed by this lecture. So we need to give a big thank you to Professor Owolabi for a job well done. The topic is not an easy one, looking at the fact that it's been there for a long time. I'm lucky for the last 25 years of doing IVF, I've recorded no mortality, but plenty of morbidity. We also need to give a lot of thanks to the inventor of the antagonist regime and those who developed the need to freeze all eggs in an attempt to prevent OHS or severe OHSS. I also want to note that this lecture has been attended by a good number of our colleagues, which is good. Like I said before, there's humongous degree of morbidity and mortality associated with OHSS. As of 2001, we had little experience when we started IVF practice in Nigeria. But we cannot stop discussing OHSS even 25, 24 years on. I'm also very happy to note that our younger IVF practitioners are present in large numbers at this talk. And that means that we continue to reduce the morbidity and the mortality associated with this dreadful outcome of.
Dr. Gukoya, sir, there's a question in the box.
Okay, just come.
Kindly look at it and pick it up, sir.
Yes, just new. Let me see.
In fact, the questions are coming in yes, in succession.
I'm very happy about that. The first one is, thank you very much for the lecture, sir. Do you have any experience, sir, in using letrozole to manage OHSS, mild to moderate? I noted that the speaker spoke about letrozole. So could I just take one more so I can take the two at the same time? Thank you, Prof, for the presentation. Please, can we have the slides? You have to keep up with the platform to know that. The next one, does IVF increase the risk of ectopic pregnancy? And if yes, how do you reduce it? The last one here is, how is fetal reduction done? Over to you, Mr. Speaker.
Thank you very much, sir. I want to thank the participant because for these questions. In the literature review that I had, letrozole was highly emphasized. I don't have a personal experience of it, but I believe from the amalgamation of the literatures, and this is the latest, literature I'm talking about, where practitioners have used this letrozole to help to reduce the pathway is already set, is reducing estrogen production, which also help to reduce the vascular growth factors that is produced.
Yeah.
Yes, so it's very, very useful. And again, of course, the use of carbagoline also help to mitigate that vascular growth factors too. And the doses have been given in the platform here, right from the day of puncture, and you can start it, or even before when you suspect, and then you pick it up from there to help to reduce. And all the factors has to be used to take care of OHSS. I've had experience with OHSS personally, and of course, I don't want to do that. That's why I had to develop my freezing facility very fast. And when we have any case that we are suspecting OHSS, because if you have primary OHSS, you can still manage and treat aggressively. Of course, you have to treat aggressively to prevent. But if you now go and transfer embryo in a woman that has already has OHSS, you are going to double the problem, or triple the problem, because you're now going to have secondary OHSS from the fertilization of our implantation of that embryo, because ACG will be produced. And that is why freeze-all is a very, very germane way of getting out of that cogmare. When the embryo is frozen, you can now monitor the woman. She's free of OHSS. The ovary has come down, and then you now plan a cycle where you now become a recipient. You now prepare as a recipient, a third party, conceptual recipient. Then you now use our frozen embryo to mitigate it. Then in terms of heterotrophic pregnancies, yes, the incidence of heterotrophic pregnancies has increased with the advent of IVF because of multiple embryo transfer and migration of, one or some of the embryo to the tube and forming a ectopic pregnancy there. And meanwhile, others have been implanted within the uterus. So, and concerning fetal reduction, yes, when I had that problem of 8 fetuses, I didn't know how to do fetal reduction. I had to go into the literature review, search everywhere and look at what to do, consult people. And we use potassium chloride, diluted potassium chloride, using, of course, you do a transvaginal scan. It's just like we are going to using ovum pickup needles, ovum aspiration needle. That's what we're going to use. And at the end of the ovum pickup needle, you are going to attach the diluted potassium chloride. And of course, you are not going to infuse more than 0.5 mils. For that particular infusion. Then you aim at the embryo that are the periphery of the uterus, because I'm going to hit, when you hit one embryo with the ovum pickup needle, you infuse a little potassium chloride into it, very, very little. the dilution have been 0.5 mils. So you put a little there, then you withdraw that needle, aim at another embryo that is at the periphery of the uterus. You puncture it again. You, of course, you are seeing the fetal heartbeat, and you put it there, and the potassium chloride is to stop, to cause the fetal heartbeat to stop, assist to the normal problem with potassium chloride. That's what potassium chloride does. And so each one, we picked about 4 of them. And luckily for us, there was no, because that process of fetal reduction can lead to one losing the whole embryo. But we had to do it, So, and successfully we removed 4 of the embryo, that cardiac arrest, and then stop bleeping, whereas the 4 continue. And that was the experience on the fetal reduction. It is very important, that one knows to be able to do that. And we did this successfully.
Thank you, Prof.
Yes.
Thank you very much. Thank you very much. I have more questions for you, if you don't mind. One is, I want your opinion on donors with PCOS. The other one says, could you please shed more light on antagonist protocol of ovulation induction? Then we have Prisa. Thanks, dear professor, for the great lecture. How do we deal with ethical issues surrounding fetal reduction, sir, in carefully selected patients? And lastly, how do you reduce the risk of ectopic pregnancy in IVF?
All right. Donor PCOS. Yes, the issue of, because of course, donors are younger age, and nowadays, because of a lot of malnutrition that is going on, there are adult malnutrition, body mass index is reducing. That's the truth among donors. And so that's why you need to be very careful with the stimulation. And thank God, luckily, because they are not going to be having embryo transfer, we still be able to go out. But the important thing is to monitor them. Low dose stimulation is part of the issue to use. And then, of course, follicular tracking, the 5 scan, you check it. If it's not enough, you can increase it. The 8 scan, then you'll be able to, up your stimulation, so that when it is excessive, you know that you need to reduce it. And of course, after the ovum pickup, you need to, because we know those of them that we already having acidic fluid even before ovum pickup. And so you need to monitor them. The most important thing for donor is post-pickup monitoring, because you don't know where some of them will come from. You need to track them, you need to educate them that, look, there is a problem, there's a danger, so that they will come back. And you welcome them back and take care of them adequately to make sure that, you set up a drip, acidic aspiration through transvaginal approach. As I said, we have to improvise to use some other bottles, some bottles to contain this thing, using the same suction pump that we use in ovum pickup. But you are now using a bigger container to contain the fluid that is coming, because there can be many. There was a 75 ml bottle that I was using, and in some cases we aspirate 9 bottles from a single case of aspiration. And some of the cases may have to come back another 2 days to do that. If it's an own egg patient, that patient needs embryo to be frozen. But if it's a donor, then what you need is adequate management. It's going to be, it will resolve. But if embryo is being transferred, then that can be very dangerous. So that is in terms of that area. Ectopic pregnancy, one of the things that we need to do is also to up the freezing facility of the center. You need to have a freezing facility so that you can freeze and reduce the number of embryo you are going to transfer. That's the thing. So if you transfer 2 blastocysts, I'm used to doing a blastocyst transfer. You know that for sure those 2, they are very good to transfer. And so when people are putting 5 embryos, 4 embryos to, and then of course they will migrate. Then of course, heterotrophic pregnancy, the important thing is that if you now discover that there's an ectopic pregnancy, you deal with it like any other heterotrophic pregnancy. You may have to operate, remove the ectopic pregnancy if it's tuber, if it's corona, and then the pregnancy can be ongoing, because we have seen many that from natural conception that are heterotropic, which we have managed. So the pregnancy, that doesn't mean that you are going to lose the one in the abdomen, but of course you must suspect and know that it can be heterotropic, not just the ectopic you are focusing on. You have to find out, is there any other pregnancy inside the womb, which will make you to diagnose that this is heterotropic pregnancy, and then be able to deal with it.
Thank you very much, Prof. Again, that is scintillating. At the moment, we don't have online questions. If we have live ones, they may come up. But while that is going on, we ought to some lights being thrown into this discussion. I know for certain that one of our colleagues who has a PhD in reproductive endocrinology, Dr. Akinola, will have something to say, especially in the area of the adrenal gland involvement in this whole saga. Is Dr. Akinola still there? Is Dr. Akinola there? Okay, if he's not around, then we will welcome.
I'm around, sir.
Oh, okay, good. Good. Nice to have you around. Can you please give us some current idea on this very important topic, especially as it relates to the endocrinology of OHSS? I'm particularly interested in the adrenal gland involvement. Thank you. Dr. Akinola, did you hear that? Hello?
Okay, I guess
Oh, I'm logging on in two places. Let me leave one.
You have to leave on one.
Okay.
Don't eliminate our own show.
Prof, sir, somebody is still asking question about antagonist protocol that you should throw more light.
Okay.
But the person
Yes, thank you very much. I was trying to recollect.
Sorry, I need to. Sorry, Prof. Let me just quickly say mine, and because I have. I just boycotted it.
You can go on. We'll come back to this question later.
What I'm saying, yes, please. So what I'm saying, Prof has done very good job. I mean, we don't need to add any more to it other than what he has given. On the endocrinology of OHSS, well, it's quite related to what we are doing in the IVF. And Prof has highlighted factors that can be diagnosed pre-IVF, and those that can be, picked up during the stimulation itself, or shortly before you trigger, or even after you trigger. So it is very, very important to prevent OHSS, because it's one, apart from multiple gestation, which is, reducing drastically in most IVF establishments, because we have realized the impact of multiple gestation, not only on the patients, the babies, but the family and the society at large. Because when you have premature babies, that is, of course, a very expensive way to go. In UK, you can easily spend £2,000 to £4,000 per day looking after premature babies. It might be more lower in Nigeria, but it's still better to prevent it. And of course, with multiple pregnancy, we can also talk about the risk to the mother herself, especially when you have triplets, quadruplets, and all the likes. We'll come back to HSS. Let me just finish with the multiple gestation. Please, it is very, very important to prevent multiple gestation. In UK, years ago, it used to be about 25% of all the assisted reproductive, all the IVF procedures done. But now, when NHS, they are very accountable. There's clinical governance. They now realize the percentage of multiple gestation in the population itself, reproductive population, is mainly due to IVF procedures, though they initiated this one at a time protocol to reduce multiple gestation, and they've been quite very successful, and they brought it down from 25% to about 5% or less. So we could benefit from their experience, and what brought it down drastically is you don't need to put 3 embryos, you don't need to put 4 embryos or 5 embryos. You can put 1 or 2. And of course, we know that if you are doing elective single embryo transfer, there is a risk of reduction, but it's still in people who are eligible to elective single embryo transfer. You can still do it. I know that is a very, very controversial thing to say in our society, because people pay for it. People say, oh, I want the maximum benefit. But at the same time, we need to think about the life of the mother herself. I just want to make a comment. Please, please, please. It is not ethical. I know, Prof, highlighted the way it's been done. Feticide, it is completely unethical. And you can go to any society, history conference or something, somewhere like that, you are talking about feticide. People will look at you, and then those who are even very religious will, completely bring you down. So please, whoever still doing it, let us completely see it. It is unethical. If the Prof said to other fetuses around, it also poses risk to the woman, because even though you are trying to target the embryo, if you instill or inject potassium chloride into any of the vaginal arteries or the uterine artery itself, and then about the risk to the woman. So if you keep to AFRH guidelines, in Lagos, it's not what obtains outside Lagos, but AFRH encourage every one of us to use it. If you stick to that guideline, not to transfer not more than 3 embryos, the risk of triplets, quadruplets, even twins are significantly reduced. Please, let's keep to that instead of doing feticide. Now, coming back to HSS so that I don't waste too much time. The endocrinology is mainly related to your stimulation, and your stimulation will cause multiple follicles, especially in those who have risk factors like PCOS. Somebody already have PCOS, somebody who already has gone through OHSS before, or somebody you can see on your scan more than 20 follicles, or even somebody that is very thin, BMI 2019. So it should be, as you think they are suitable for intrauterine insemination. We should be very careful. Prevention is better than cure. And if we delve into that, then we should do, costing is still available, is still good. Cancel the cycle. We can also do a freeze-all, and then antagonist cycle, as curb all the excesses. Antagonist cycle, you only need to trigger with GnRHA. So that significantly reduces OHSS risk. In most of the donors, donors that we have nowadays are young girls. The risk of OHSS is high. Some of them low BMI, some of them PCOS, excepting those who have already gone through multiple retrievals. So if you are going to give them, if you titrate your gonadotrophin concentration to the weight of the baby, there are protocols you can use, gonadotrophin antagonist cycle. Most of the donor cycles should be actually antagonists. Most of our cycles should also be antagonists. The only one that you can think about doing the long protocols, maybe those who are in the realm of poor ovarian reserve. Even though those people, antagonists will do well for them as well. So the main thing apart from the prevention, is also to treat, and Professor has mentioned it, refer these patients to establishments that can look after them, multidisciplinary. We have degrees, mild, moderate, and then severe. In severe cases, needs multiple. And what are the means? You need to, one, rehydrate the individual. You can give carbaglin. When you are rehydrating, you're going to be very careful because the vascular volume is low, so you don't want to overhydrate. And you can give albumin, serum albumin, to drive back, the liquid back into the vasculature. So these are procedures. Yes. Then these are procedures we can do, but if you can't do it, please refer the patients. This is still one of the main causes, but thank God, antagonist cycle and freeze-all cycle have removed most of it. We'll stop here and let
Professor, thank you so much.
So thank you so much.
Thank you so much. We have the last question here. The last question here is from Dr. Owolabi, one of our colleagues. He says, is there a role for dual trigger in PCOS patients with a risk of immature oocytes? What's your experience with HCG or leuprolide trigger in POS? That's the last question.
Thank you very much. I want to just quickly respond to the issue of, petocytes should not come up at all. Everybody should work towards getting that not available. But the unfortunate case that I had, and that woman was going. It was a terrible symptomatic situation that you just have to do something. Either you terminate the whole pregnancy or you reduce. Because HSS, there are some cases of HSS that you need to terminate that pregnancy. That woman will die. So in cases where a woman will lose her life, that baby will go for it. It's basic. So the ethical issues, they are there, but when something is life-threatening to a mother, then that baby will need to be sacrificed. So that is one area. But the best thing is to prevent it. But if it happens, the life of that woman is going, where are you going to be the mother? So those babies will go. And the process of doing that, you may even lose all those babies. And then, of course, multifetal pregnancies, we have miscarriages, which is very common. Despite cervical sacrilege, in some cases they still have miscarriages. So why go to that length to cause more trouble? Upon all, do no harm. That's the adage in medicine. So I don't have experience with dual trigger. I think it's things that are coming on presently, but I think one can look into it and explore the possibilities.
Thank you very much. Thank you. Professor, we want to thank you very much and say we also thank you, especially because you kept to time. Your lecture, even though voluminous, still kept to time. Amazing. And apart from that, I enjoyed the simplicity of the presentation. Easy to consume. Good lunch. I want to encourage all of us to register for the upcoming conference in September from the 24th to the 27th of September this year. It's going to be one like none before. Our bi-monthly webinar, of which this is one, is coming up again in 2 weeks' time. Endeavor to join. Our secretariat is always very active in making you aware of this. Let me pass you back to Dr. Akisoya.
Thank you very much, Dr. Ogunkoya. We all agree that it's been a very still cautious about the volume of the culture medium we use, not allowing to be too much. We can also reduce the risk of having an ectopy following IVF. Also, catheter placement is very important. If you place the catheter in the right place, the possibility of ejecting and allowing the embryos to get into the tubes is also reduced. Also, background tuber disease could also increase the vulnerability for ectopic implantation. That is that on that issue. So we want to thank Prof for this very scintillating discourse. We all agree that it was well discussed and very highly informative. Thank you very much, sir, for accepting to do this. We appreciate you. And on behalf of AFRH, we say a very big thank you. We also want to encourage our attendees and remind them that it's a bi-monthly webinar, and we expect to see everyone, even a bigger crowd, in the webinar coming up in September. Thank you very much. Thank you, everyone. And from all of us here, it's goodbye and see you in the next presentation.